Dear visitors of the European Heart Journal Today website, I brought you today two true legends in cardiology who certainly do not need any introduction. Professor Val Fuster, Professor Salim Yusuf. And they're going to talk, they have so many favorite topics, but they're going to talk today about polypill strategy and latest news presented here at the European Society of Cardiology meeting, the world's leading cardiovascular meeting here in Barcelona. Professor Fuster, you're going to present tomorrow, actually. We're ahead of it. It's going to be embargoed, but you can talk about it here. What are you going to tell us?
Well, I'm going to talk about the concept of the polypill, concept that actually Salim developed in 2002 together with other British groups. And basically, in patients post-myocardial infarction, the adherence to medication tends to drop about 50% based on the literature. So we did the study in two parts. One is in 5 countries, Spain, Italy, Paraguay, Brazil, and Argentina. We look at 2,000 patients with myocardial infarction, and we look at adherence by the refills in the pharmacies. And we found that 50% were not adherent to the medications, which is already in the literature. Now, from these 2,000 people, we look at the factors by which people decrease medications, and we found 5 that were very striking. One is young age. It's like you get more loose. The other is the number of medications an individual is taking and the complexity of the treatment. The other is significant depression. The other is lack of social support. And the 5th one is the type of insurance that you have, if you are covered or not. And these 5 factors were very significant, telling us that we have to pay attention to those.
Yeah, drugs don't work and those who don't take them.
So this is the part 1. Yeah. Then from this group, we got near 700, we randomized them in a polypill, which is what we give following myocardial infarction. The polypill had aspirin 100 milligrams, simvastatin 40, and ramipril 2.5, 5 or 10, depending on how the patient tolerated. And the other group took the pill separately. And basically we look at adherence by different methods, but all boil down into a significant decrease in adherence in the group that took the medications separately compared with the group that used the polypill. So this is leading us now into thinking on a prospective randomized study in looking at events, and we are in the process of designing it over a world type of a study of over 2,000 people with myocardial infarction, if they can be randomized into the polypill versus the 3 pills separately, and then looking at events, which is the real thing. And actually, you, Salim, have a lot of experience already in prospective studies with the polypill. So the way we see it, and maybe we might work together on this, is to really move into the clinical events. We already know that adherence is less with it.
Yeah. Salim, these are worrying numbers. Did they surprise you?
No, they don't surprise me. Actually, the numbers Val quotes are optimistic rather than pessimistic, and Val knows what I'm saying, because you see, there were 2 reasons why I say they're optimistic. First, these were all people in contact with the medical system. A large proportion of people post-MI stop going to the doctor, and obviously then they don't take anything. So in real life, adherence is worse. Second is in the trial, in the focus design, they made it really difficult for themselves, because they gave the 3 drugs in the control group, they purchased it and gave it to the patient. In the real world, that doesn't happen. So it's actually a tough test. And despite that, the polypill improved it. So in the real world, the difference between the polypill and no polypill may be 3, 4, 5 times bigger than what is seen in the focus study. So if you said if the study were usual care, which is do whatever is usually done, versus the polypill, I think the difference would have been much bigger. So I think the polypill needs to be seen not as a new drug. It's all existing, proven, safe, generic drugs. It must be seen as a delivery system. We're delivering the drugs in an effective manner. And my expectation is, because you're combining many drugs, your packaging, your distribution, your marketing costs will be lower. So you may be able to give it at half the cost of giving each one separately, or even lower. And then if you say we have a health systems approach, because you mentioned insurance, but let's think of another system, that the insurance company actually buys the polypill in bulk, not at retail, but at bulk, and distributes it. Then the cost will even go further down, because they're buying it in bulk. And so I see this as a very effective delivery system to improve adherence at multiple levels. First, at the physician level. The physician doesn't have to sit down and write four different drugs, just one word and all else given. Second is the patient level, and third, it's at the cost level for the healthcare system. So the system will be better adherent, the physician will be better adherent, and the patient will be better adherent. And I personally think where we already use these drugs, like secondary prevention or high-risk primary prevention, we shouldn't need trials on mortality, morbidity, because it's proven individually. Okay. And so really, I hope the regulators will put on a hat that is more public health oriented. Governments and insurance companies will put on a hat that's also systems and patient oriented, and say, how can we get proven drugs to the patient at a low cost? And the future may well be that it's not physicians who are prescribing this. They may initially prescribe it, but non-physicians may be the ones who check on these, or you may even be sending this to the patient by mail. Suppose you're part of the insurance company, your insurance company sends it to you every 3 months, and then you get a bonus for being adherent. Now, focus 1 is actually very important, the first part, looking at the causes of non-adherence, and there are many. Obviously, if you're taking 8 or 10 pills, and if you can reduce it by half, that's a big step. But the other factors, distance to the doctor, well, you can circumvent that by having non-physician health workers or mailing the drugs. Or when a patient has to go to see a doctor, they take half a day or a day off work. They lose their wages. They have to spend money on travel and parking or bus. You can bypass all that. So I see the polypill as a catalyst for systems change. I don't see it just as a pill. And I think in cardiovascular disease, we know a lot of things work, but we don't use them well. So now we need to start to think of how do we use them well. And the polypill is not the total solution, but it's a key part of the solution.
Really provocative what you're now suggesting. Of course you are, that's why we love you, Salm. But do you agree with that, Val?
Yeah, no, look, I have very little question. If adherence is a huge problem in society, we have to solve it. And the polypill is an instrument part of the solution, and I am in agreement with Salim. This is coming. And the question, obviously one of the questions here is, do we have to prove that the number of events decrease? Academically it would be nice, but it has been proven already in a way, because these are pills that are necessary. So I am in agreement with the way he says. He says the same thing I would say, but with a lot of passion.
I thought you were the master of passion.
Well, I have Mediterranean blood, but but I feel the same practically.
But the polypill strategy, of course, will overcome the problem that with too many drugs you're not adherent anymore. Yeah. Of course. What are we going to do with the young people? They're not taking it. That was a surprising finding. Not really.
We need a lot of education here. I mean, look, I think one of the great problems is one of the issues, actually, he said something interesting. This is not a new pill, so we don't have to start discovering the world. This is the way you deliver it. And we have to work there. And then the young people should really learn that their health is at stake. And I think this is one of the issues that we really have to get into.
So, just a sec, would you really send your pills out via mail to your patients? Is that something? I know, but
it's happening in the US.
Aren't we as doctors there to monitor side effects, measure blood pressure in a patient who is on an ACE inhibitor. Uh, Even statins are very well tolerated. We don't want to get into that discussion.
Well,
but I
aspirin is
know.
well tolerated too.
I know.
The ACE inhibitor, we use it 3 dosages, but I want to tell you, you're dealing with your problem. We are telling you a problem is a huge problem, so you always have to compromise here. Sure, side effects and so forth, but look, if 50% of the people don't take the pills, or more, even in poor countries, in fact, no more than 10%.
10%. But Frank, I get your point. You see, I think, step back. Cardiovascular disease eventually will affect about 1/3 of populations. It is the biggest epidemic mankind has ever known. How do we solve epidemics? We don't solve epidemics one patient at a time, one doctor at a time. We solve it through mass approaches. So here is a strategy. I'm not saying the doctor is not relevant. The doctor is relevant. The side effects of the polypill are easily identified by the patient. I feel dizzy. That's patient can tell you that. You don't need a blood pressure cuff. Okay. The patient can tell you, I've got a cough from my beta blocker, or ACE inhibitor, or whatever. GI, I got irritation from aspirin. I've got muscle weakness. These are self-reported. Now, these self-reported ones, you warn the patient, and you can have a system where they can call into a line, or they call into a nurse or a non-physician, and if the side effects occur, then the doctor intervenes. And there aren't enough doctors in the world, even in the rich world, to deal with everybody with chronic vascular disease. So we need a new model. And look at that, in my hospital, I'm sure Val's and yours, who runs the majority of patients with heart failure? It's the nurses, and we help them. Do you know how in Zambia, HIV was a very big problem? It's still a big problem, and most of Africa. They didn't have enough doctors and nurses. They had non-physician health workers. And managing HIV is much more difficult than managing blood pressure or secondary prevention. You have to use multiple drugs. They've got much more side effects. They interact. They get opportunistic infections. So if an African high school graduate can manage HIV, I'm sure our much more well-trained people in a simpler condition can manage it. So I'm looking at this as, how do we solve the global epidemic? To me, the polypill is one vehicle, one tool in your toolbox. It is not everything.
Oh, sure.
You know, you need the whole system. And it's time for us to change the way we think on delivering prevention. And will that put cardiologists and doctors out of business? No. We've got a lot to do. We manage the difficult cases, and let the simple cases be managed by non-physicians or even self-management. Like in Africa, again, another strategy to improve adherence is what's called patient supporter. We're using that for the polypill in a trial in Colombia and in Malaysia, where you train a family member to support the patient through the issues. And it's no more than a well-meaning wife henpecking the husband. Have you taken your pill? And it works. So when you think of it, what I'm saying is just common sense. It's not revolutionary, and I don't think doctors should feel threatened at all, because honestly, we're not dealing with the problem.
We have been dealing with the polypill in hypertension.
We have.
Yeah.
You know, so this is not
gets 3 drugs.
Exactly. So I don't think it's an issue. I think we should not be afraid. We should move forward. And I think what Salim is trying to tell us is that we have in front of us a significant problem, and we have a very simple solution, part of the solution. So we should not get away, and we should move forward. And actually, the polypill is certainly one of the instruments, and there are many others. But at least we are getting into the data, and the data is pretty strong that this might have at least something of benefit.
So how do you see that we have to come to an end? Give us an outlook to the future. In 10 years, when we come back to Barcelona in 2024, where are we there?
I can tell you the following. The last 10 years, 20 years have been treating disease. These 10 years to me is identify subclinical disease. The following 10 years will be to promote health. This is my view.
I think I agree with that, but I'd add one more thing, because you said, what about the young people? We must remember the pills are not a substitute for lifestyle modification. And the standard approach has been you first try lifestyle modification, and when it doesn't work, you do pills. I think you do both together, and you can use the pills to promote lifestyle. For instance, let us imagine we have a packaging for the polypill, and on that give rotating messages on stopping smoking, healthy diet, exercise. So let's now have a comprehensive strategy, and lifestyle management is very important. And young people, of course, we're not going to put them on pill unless they have very high cholesterol or very high blood pressure or something like that.
Final message that has nothing to do with the polypill, but has to do with what he's saying. You know, we are working with children aged 3 to 6. That's when we develop the behavior on a disease that actually is very behavior related. So we have a lot of data in this young age, spending 70 hours on health in 6 months to children between age 3 to 5. The success of the program with a follow-up of 3 years has led now we are working with 70,000 children between Europe and South America at this moment, with programs that is just getting in childhood, which to me I think is also has a very significant future.
Well, these are wonderful, famous last words by Fusser. I promised you 2 legends, and that was really great. I enjoyed it. I learned a lot. Thought-provoking, as always. But you paved the way for the future, and thank you so much for joining us here on our website. Thank you.
Thank you, Frank. Thank you, Val.
Thank you.